determine any baseline. So you would have to say that at that point that strip is indeterminate. Category 2. Here's some nice variable decelerations, all different sizes and shapes there. Variables are visually apparent and they're abrupt. That's the thing, they're quick. They might last for a little bit longer. On some of those, some of those do last longer, but they're abrupt change below the baseline, and the fetal heart rate usually decreases about greater than or equal to 15 beats per minute below the baseline, lasting about 15 seconds. But they do need to be less than 2 minutes in duration. Otherwise, you're entering into that prolonged deceleration sort of area. The onset, depth, and duration commonly vary. We used to have what we called a variable deceleration with a late component, and that's just something you don't see anymore. You don't look at the timing. The timing doesn't matter because the physiology is the same regardless of when it happens. And so let's talk about that. When you have a variable deceleration, that is umbilical cord compression. So what happens here is as the baby's cord is compressed and those veins and eventually arteries are occluded, babies are smart. They start to increase their heart rate a little bit to make up for that decrease in blood that's getting to them. And then as they're pumping more, then that's like, pumping against a closed door or a closed valve, and the babies are pretty smart. So they say, oh my gosh, this is really hard on my vascular system. So it causes some baroreceptor stimulation, and the heart rate goes down. And then as the contraction is starting to end, the pressure is released and the baroreceptors are stimulated and start to increase the heart rate back up. And then you usually get a little bit of a recovery after that, a little bit of an overshoot where it speeds up and then back to baseline. So for the test, variable deceleration is umbilical cord compression resulting in baroreceptor stimulation. So here's a few nice ones in relation to the contractions, some a little deeper than others, but they're all abrupt and they all recover very quickly. So your first line of defense on those is you want to try some maternal repositioning. Here they put an amnio infusion in, so they did want to try to do some amnio infusion even with her being 8, and that's appropriate too. But you do have to, like I said, be a little careful that you're getting fluid back out. At that point, you don't want to have a rising baseline or rising uterine tone. A little bit deeper, but they are abrupt, and they do not last longer than 2 minutes. They look a little uglier, and they are late in timing, so we don't comment on that. That doesn't matter as much. There could be a little combination of things going on there. There could be some cord compression, and it is affecting the uteroplacental perfusion. But your treatment is still the same, and if you had to call those anything, by definition, those are variables. Just another example of a strip here with some variables. And now let's talk about prolonged deceleration. It's a visually apparent but decrease in fetal heart rate greater than or equal to 15 beats per minute below the baseline, and it needs to last greater than or equal to 2 minutes. So if you do have a 2-minute one right at the 2-minute mark, then it's still a prolonged, but less than 10 minutes, because if it's greater than 10 minutes, then it's considered bradycardia, and that doesn't change really what you're going to be doing, because if you have a baby that goes down and stays down for more than 10 minutes, you're still going to do probably the same. And as you're watching it, you're thinking about moving to C-section. What's usually happening during a prolonged deceleration is most often it happens during uterine hyperstimulation or hypertonus. If you have PIT on and your patient is contracting or has a real tetanic contraction, then your baby will respond to that. If you have an acute insult like an abruptio placenta, you'll have a prolonged deceleration. If you are assisting with an epidural placement and your mom has a hypotensive episode where she really bottoms out her blood pressure, you'll have a prolonged deceleration from that because your baby's not getting any perfusion then. If you have a uterine rupture, it's an acute interruption of the blood flow to the baby, so you're going to have a huge decel. If you have maternal hypoxia, where if you have an eclamptic patient and they have a seizure, they're not breathing during that seizure, and so that can definitely cause a large deceleration. Or if you had a patient perhaps that was over-medicated, maybe she's self-medicating and you medicate her as well, she could have some respiratory depression and you might have a decel because of that. Umbilical cord accidents cause prolonged decelerations. If you have a short cord and you're approaching your delivery and you could have a tear or something very bad, that would cause a deceleration. You might have some terminal fetal conditions. If perhaps your mom has had some drug abuse, or maybe there was an asphyxic episode during the pregnancy earlier on and this baby had a stroke or something, you might get a strip where the baby is getting to the end of where it's going to be actually viable, and you might have something like that. If you had a ruptured vasa previa, again, a bleeding incident. A vasa previa is where the cord inserts along the amnion, a bag of water, and if the patient's water breaks or they have artificial rupture of membranes, you could lacerate a large vessel, or even the cord could separate from the placenta and cause a huge bleed. If you have rapid fetal descent, and I'm sure you've seen this in practice, if all of a sudden your patient goes to complete and the baby just boom right down, that's a huge vagal response of the baby as they just fly down. And vagal stimulation can also cause a prolonged deceleration if your mom is throwing up or something, or she's pushing really hard Valsalva through a closed glottis. It could cause that also. Here are what looks like some late decelerations, but by definition, if you look, it really is a prolonged deceleration. It tries to come back up, but it never does come back up to the baseline, and it lasts, several minutes there, depending on where you view the strip and what you say your baseline is. It's over 2 minutes at least. And it's probably from that hyperstimulus there at the bottom. Here's what looks like some pushing perhaps and some hyperstim, maybe injudicious use of pit. But there's lots of sort of variables, or probably variables there, but again, looking at it, if you go back to your analysis in general, can you determine a baseline? Probably not, because you have a lot of, you could even almost say marked variability, but there's no good baseline. There's probably variables there. When she's pushing, can't determine baseline, and then as she continues to push at the end, then you have a prolonged deceleration. But your goals are going to be the same. You're going to reposition, you're going to do IV bolus, and you're obviously going to do something with your uterine activity. If she's not on pit and you can't turn it off or turn it down, you're going to try to have her perhaps push not so frequently, maybe every other or every third, to see if you could give that baby a rest. So, and your other interventions, IV, bolus, oxygen, things like that. Just another example. And if you have something like this, you don't even have a little section enough to determine a baseline, so you can say indeterminate. You've got a variable there, and then a prolonged, or really a prolonged with a little variable mixed in. But if you look at how long your decel is there, it is over 2 minutes, so that's a prolonged decel. Okay, one more review of your little chart here about your fetal acid-base status and your critical thinking. What do you think your acid-base status is? What do you think is the underlying cause? And we reviewed all the decelerations and what causes each thing. What would guide your in utero resuscitation? So first of all, if you're thinking that it's cord, your first thing is positioning. So that's always your first right answer. If it's late decelerations, then you're thinking placenta. So how are you going to increase your perfusion to your placenta? If you're having contractions, you want to alter that. Your contractions, you want to lessen your contractions. Again, you can always reposition. Fluid bolus is good, and O2 at that point, you're going to want to do some O2. And then if those things don't work, are you going to consider prompt delivery? Now we're going to talk about bradycardia. Bradycardia, by definition, is fetal heart rate less than 110 beats per minute for greater than or equal to 10 minutes. And we know that in practice, we see babies on MAG and other medications that will run low baselines. Methadone will do that too. Oftentimes those patients are kind of known to have that sort of lower heart rate, and they come from the office with documentation that's what it's been in the office. If you get a post-term baby too, they do have a lower heart rate. So it can be benign, but it does require further investigation. Now that's ugly. That's just plain ugly. And I know that if you guys had something like that, you wouldn't think, oh, this baby's probably okay. You would definitely do all of your intervention measures and further investigation as to why this baseline is so low, with notifying your provider to do a bedside evaluation, things like that. And if that's pit on, you're going to turn that off, obviously. And also keep in mind, if you have something that is so low like that, or anything, it's just good practice once in a while to apply your pulse ox to confirm. And if anyone looked at it after you, if you had something happen, they could see your line of thinking that, yes, I just need to confirm that I'm always monitoring the baby. I don't have the mom on for some of these times. And the bradycardic ones especially are important, and I think you guys already know that. So as this happens, and the baby is deprived of oxygen, there is a cascade of events that occurs. Normal blowing off of CO2 and the fetal metabolism is aerobic, and that works well, and they can, with their fetal hemoglobin, they can exchange all the CO2 and keep their blood at a normal pH. But as hypoxemia happens, meaning that low oxygen in the blood, that results in some tissue hypoxemia. So then as that happens, the Krebs cycle and all of those things start, going back to what we had learned about all of those. Then anaerobic, without oxygen, metabolism happens. And then as that happens, it's it's not a very good, efficient use of ATP and oxygen. So then it causes lactic acid buildup. And if acid is present, then that contributes to that metabolic acidosis. And so those babies need to try to get reoxygenated so they can blow off that CO2. I included this on here to remind you, because we talked about this in fetal monitoring. Most people, if they're exercising, they have a certain cardiac output. And cardiac output is determined by your heart rate times your stroke volume. Babies cannot relax their hearts to accommodate a bigger load of blood to pump more. Babies can't regulate their stroke volume. They can only just raise and lower their heart rate. So I want you to keep that in mind, because I think I just kind of recall something on the test about that. So for baby, their cardiac output is only related to their heart rate, not their stroke volume, not like us big people. All right, let's talk about tachycardia. Baseline fetal heart rate, by definition for tachycardia, is 160 beats per minute for greater than 10 minutes. and you all know already about maternal or fetal infection. If there's a temp, and even if there's not a temp or just a low-grade temp, that can cause a definite rise in fetal heart rate. If a baby has progressive and continued interruption of fetal oxygenation, where there's a lot more, too many contractions, a lot going on, you can see those rising baselines where you get some tachycardia. If a baby has had an event where it had some bleeding, excuse me, and they have some anemia, you'll have some tachycardia. If you have maybe an untreated maternal hypothyroidism, you'll get hyperthyroidism, you'll see some tachycardia. And babies can have benign fetal sinus tachycardia. Generally, that's a known thing that happens and it's transient, and the providers usually get an evaluation from maternal fetal medicine on that. And you all know that there's medications that patients do take, and coffee and things like that that can cause some tachycardia. Here's a nice tracing that overall isn't terrible. It's still got some moderate variability there, a couple of variables, but your baseline is, it's varying there between about 170 and almost 185, so you would kind of pick that middle ground for your baseline. And you're going to be checking temps and things like that. And I think that you probably have seen in practice also, sometimes the moms don't have a temp, but the baby will tell you that there's something going on before the mom even registers a higher temperature above normal. This one I included because I want to just make you aware that in some cases it's a fetal tachycardia because there's something going on. It might be benign, it might not, but obviously you're going to check with your provider, and they're going to evaluate this because the patient may have to be transferred for digoxin or some medication treatment to help that baby to convert its heart rate. So on that, you're going to troubleshoot your monitor, make sure that that's really what's going on there, and also put the pulse ox on. Keep in mind that that could be a half of a rate. That might be half of that. So you'll need to just go through your steps to troubleshoot your monitor and make sure that's what it is. And rely on your hands and ears, and maybe take the monitor off and get a Doppler and try to auscultate and see if you can hear anything, and try to count that to see if that's really actually what you're hearing. Okay. Little table of drugs you just need to memorize because there are questions on the test about that. Sympathomimetics, things that we use to treat preterm labor, like terbutaline. Ridodrine is an old-timey drug that isn't in use much anymore, but that's a tocolytic. And albuterol, if you have a mom that's asthmatic and she gets a breathing treatment, get some albuterol. That can cause your baby's heart rates to increase. Parasympatholytics, atropine and phenothiazines, we don't see much in use here because if there's something going on where your mom needs these medications, we're generally not taking care of them. So these are all drugs that cause tachycardia. Also, you've seen in practice, caffeine can make your baby a little tacky, but most of our caffeine, our coffee drinker moms, their babies are kind of used to it. Also, I didn't include on there smoking. Nicotine can cause a rise in heart rate. And again, goes back to our smoker moms. They're smokers, and they've been smokers, so the babies are used to it. You might not see it as much. Definitely street drugs like cocaine and methamphetamine are going to cause a high rise in heart rate. This just illustrates a little bit about babies just slowly telling you that there's something going on. So this patient's been ruptured 30 hours and she's shaking, she's got the chills, and her temp is elevated. At the bottom, I just want to point out that, and it's good to know that if you've got something going on like a choreo or something, that's really irritating to the uterus. So you're going to have probably almost a tachysystole type of pattern. You're going